Okay, right, fine. Well, good evening and welcome to the pre-Rosh Hashanah event of the Jewish Medical Association webinars on COVID-19. We're delighted to have tonight Adrian Tookman, who worked at the Royal Free, works at Marie Curie, and modestly left out things like he was the kind of lead palliative care doctor in the country for several years. Adrian, apart from that, is a friend, and of course, we brought together by the professional connection between my wife and him, working in the Royal Free, I think, 30 plus years ago at this point, when they originally met. Anyway, it's a pleasure to have him here. We never thought that he would be coming along to talk in such uncertain times about dying, but thinking about his title, we really are in very uncertain times, and we're very pleased that he's able to come and give us some insights about this from the position of palliative care. Adrian.
Thank you, David. Thank you, David. I'm glad you said it was a professional relationship I had with your wife. Very useful. Thank you. Dying in uncertain times. I'm going to flick through a large number of slides to try and make a point. And I'm going to speak for about 40 minutes, and it's 15-20 minutes for sort of a chat, really. So uncertainty is a big issue, and uncertainty is really, it's a word that is not well understood and badly handled in the medical world. So I'm going to break this talk up into three. So the first bit is about uncertainty in my speciality. So the uncertainty agenda is huge, and I always like to show this one. Yeah, no one quite knows when they're going to die, really, do they? So uncertainty is there all the time, but death is in society in general. And I'm going to explain why I said that as the presentation goes on. So this is me. What am I? I'm a palliative care physician. Went into palliative care in 1985, which is 35 years. Is it 35 years ago? I think it's 35 years ago. 35 years ago, I was in the cohort of palliative care physicians, the first cohort. There was 30 of us. It became a speciality in 1987. I am the only one left in practice of that cohort of 30 people, and I'd be very flattered if you put in the chat box that I don't look old enough. What do I do? Progressive life-limiting illness, cancer and non-cancer, focus on controlling symptoms rather than curing, and includes hospice care. So this was a hospice in 1985. You went there to die, but actually things have changed. It's not just about caring for people who are dying. So why are things changing? And perhaps we should say, before we do that, who's the best in the world at end-of-life care, palliative care? And this was 2015 Economist Intelligence Unit study, where, oh, it's me who's the best. And the reason why is when we looked at the best place in the world to die, according to the end-of-life care index for the Economist Intelligence Unit, we did the best. We're number one on the list. Interestingly, as we're the Jewish Medical Association, Israel is down at number 25. We're at number one. And I pointed this out to Yaakov Litzman, who is currently the Minister of Health for Israel, when he visited the UK, and said I could give him some advice. And he said to me, you don't need to, because, and he opened up his prayer book and said, it's all in my prayer book. They're still not as good at palliative medicine as we are. And there's lots of things to say about what is happening in Israel with their rate of COVID patients. So nothing happens when everything stays the same. Okay, let's just sort of get into the palliative care world. So we're the best, which is great. What is going on in cancer? And this is a chart just showing the rise in survival that's happened over the last 30, 40 years. So cancer, and I look after cancer and non-cancer, but the 10-year survival rate is clearly increasing in the cancer world. And this was a talk that was given at CHI. I work with a CHI team by David Chow, who's a consultant oncologist, And he gives this really interesting talk, and he gave it a couple of years ago at High. He's a melanoma, renal and lung man. And the bottom line is that he says, when I started in melanoma and renal, if you got melanoma, renal with lung mets, metastatic disease, you had no chance when he first started. But actually now, we don't quite know what's going to happen with metastatic melanoma and renal because of the new therapies that are out there. So uncertainty comes into the world of cancer significantly. Here's a survival curve. That curve is skewed to the right with all these new therapies, and therefore assessing prognosis and survival is becoming a much more challenging task than it ever used to be. It was always difficult. But I guess the other thing to add to this is the curve is shoved over to the left, because you don't die of cancer now, you die of a bit of cancer, a bit of lung disease, a bit of renal problem, etc., etc. As we are all familiar, the comorbidity agenda is massive and not well managed in our healthcare system for reasons I will explain. Multimorbidity mortality, this is a longitudinal study that was published a couple of years ago, and I'll just highlight the things. So the number of people living with multimorbidity is high, risen considerably in high-income countries. I think that's meant to be us in the last decades. Multimorbidity is associated with increasing healthcare use. Yes, we know. Higher costs, of course. Quality of life, mental health symptoms are massive. Fragmented care is pointed out as a real problem. Despite ongoing research, healthcare systems are still better prepared for handling single diseases, because they focus, all of us focus on specialism. Of course, that's not the case in primary care, care of the elderly, etc., and in palliative medicine, but there is siloed medicine, and siloed medicine, managing this uncertain, complex population, is an incredible challenge in the new healthcare systems, and we need to think in a different way. There is no doubt about that. This is the, so 1985, let me take you right back again just to reinforce this conversation. So this was work done by Scott Murray, who was a now retired colleague of mine. He said, this used to be the cancer trajectory. Okay, you went around for a while, got a little bit worse, and then you got your recurrence with your cancer, and you died within weeks or months. Okay, it was dead easy palliative medicine then. That's when I got involved. Now, this was the chronic illness trajectory. You go along, you get an episode of chest infection or something like that, or heart failure, you get unwell, then you get better again. Not quite as well as you were, but you get better, and then it happens again, and then what happens is you have one of these things, and then you die. That is the chronic illness trajectory. Where do I get engaged? That's fairly easy too. And this is the dementia trajectory. So this is frailty and dementia, and we wobble about, the curve wobbles, it's all very unclear what's going on, and then patients die of cascading multiple health problems. Where do I get engaged? Well, difficult to say really. And this is a real challenging trajectory. And the reason I present these trajectories to you is to say, actually in cancer, the new trajectory is this one, not this one, and not this one. And as I said, multiple comorbidities is often a cause of death, cascading health, but unpredictability, uncertainty. It is very difficult to know where we all become engaged and how we manage these patients, because we have very siloed medicine. So just to add another line, what are the chances of living to 100? 1 in 3 of today's babies will see their 100th birthday, according to latest estimates. Actually, the population is living and it's older, but it's not living a longer time well. And really, we need to think in terms like disease-free survival rather than how long you live. We've got to think about, how much of your life you'll spend with disability and how much you spend able-bodied. And the consequences of all this are comorbidities, multimorbidities, the prehabilitation, the rehabilitation agenda is absolutely key now. We're seeing these new complex problems, frailty, chronic pain. We need to manage things in a different way, and the long-term consequences of cancer and its treatment are sort of, we know about radiotherapy, chemotherapy at one level, but the long-term consequences of the new therapies is difficult to know. We do not know what is going to happen with these people who are surviving with the new biological therapies in 5-10 years' time. So uncertainty is huge. What do I do? Well, the first thing is hope and expectation. Patients present to us, as we're all well aware, with a hope and expectation they're going to get better. So what do? Quality of life values. And then the trouble is with our population, we often have people who say this. This was a book I gave to my children, and I now read it to my grandchildren. So we all know this, how this works. And the reality very often when people present to us with multimorbidities and complex problems, the reality is the likelihood of cure is low, particularly in cancer. Disability may be the result, and maybe the result of arduous treatments. And when you've got this big gap, it's called the Kalman gap, the gap between hope and expectation and reality. And what do we try and do? So to improve the reality, this is my job, good quality symptom control, managing the physical, emotional, spiritual, and social well-being of patients, doing things properly, pushes that reality upwards, because we've got to try and close that gap. And also with good, honest, sensitive communication in a trusting therapeutic relationship, we try and make hope and expectations more realistic. Closing the gap is the key to my work. And when the gap is wide, you get the defeated, abandoned, cheated, resentful patients, those who are living with huge uncertainties. And lastly, before we move on to the next little section, is Cicely Saunders set up palliative care in the 1960s, 70s, and said, you've got to treat people holistic. You've got to look at their emotional, social, physical, and spiritual needs. In fact, this concept is a great concept, but it needs to be expanded. So myself and Dr. Gishan published not that long ago, 2019, it was last year, we published to say, actually, this circle has to be expanded because people live with significant problems with intellectual impairment. They don't like that. It needs to be considered. I don't know about you guys, but I look at my bank balance almost every other day, and I've no idea why I do it. And if you have financial problems and you can see, you're not earning money, etc., it's a huge, big issue in terms of holistic symptom management. And sexual dysfunction is common in people with complex illnesses and needs to be handled and needs to be managed. So we've expanded holistic care. So our skill set, complex need, we have to assess with holistic assessment, multiple comorbidities, complex symptom control, coordination of care is key, and I'll come back to this, primary care, community, health and social care, keeping people in their own homes, and good communication. When we talk about good communication, we need to allow patients to express their preferences and wishes with very good advanced care planning. We're dealing with complexity. And just to reinforce, siloed medicine is needed. We need specialists, but we also need ideas that join up silos, that transcend silos. And if anyone's got any ideas how we do that, please join in the chat. So there we are. Smell the coffee. This was written by Anne Landers. Actually, that was Advice, Wisdom, and Uncommon Good Sense. That was the original book. That's how the phrase came. And then suddenly, in February, in comes COVID. COVID-19, which increased the uncertainty agenda by many, many times, as I think everyone is aware. Now, forgive me, I'm going to use lots of words with these slides, and there's a reason why, but please just allow me to focus on some of the key issues. So COVID came in sort of February, March. COVID became at one level a time when everyone started doing things like Zoom meetings, David, and lots of meetings, and people. Interestingly, there's a downside to the Zoom meetings, and this was one of the downsides. The first meeting held by this group was on Saturday, March the 21st. I mean, that's a, that's a big threat to the Orthodox Jewish community, isn't it, really? That kept them out, as they say. So this was a joined up meeting. I'm sure that wasn't done on purpose, with the Royal College of Nursing, Royal College of GPs and Hospice UK. And they set up a pandemic group to look at ethical principles. And because I've been around, probably because I've been around for so long, I was invited onto this group to look at the ethics from a GP pair of eyes. And I just want to focus on a few things that were discussed in the original few meetings. So looking at ethics, respect. So people's personal choices about their treatment and care should be respected as much as possible. Yup, absolutely. Where the healthcare team's views on appropriate future treatments are at odds with those of an individual and those close to them, a second opinion should be sought. And you can see that this ethics group was trying to foster good ethical care, because there were huge problems at the beginning of the pandemic, as people on this call will all remember. Minimizing harm, balancing risks in a proportionate manner, and we'll talk a little bit more about that. Fairness, working together, reciprocity, keeping things in proportion, flexibility, use the latest evidence or expert consensus. And as everyone knows, there's been a lot of sort of interesting diversity with experts in this area. And good decision making. Seek second opinions and cross-check decisions with peers. And this is what was going out to the general practitioners in situations where flowcharts and guidelines are not sufficient. In other words, tick boxes don't work in people with very complex illness who were dying then very rapidly. And talk with respect to professionalism and compassion. Talk with respect to professionalism and compassion. So fundamentally, this was an ethical group. And what happened to this, the first meeting or two, there was a whole thing, a series of things that were going to go wrong, we thought at the beginning. Firstly, all services will be overwhelmed. Secondly, there's going to be no beds around. We spoke about running out of drugs that were going to be used for end-of-life care, particularly the use of diamorphine and midazolam, the two key drugs used for dying patients. And there was a long discussion that we had in the this meeting here to say, what happens if there is a real crisis? Can we think right out the box and think of some of the things we should be doing if we are running? How can we ensure that the right person gets the drugs, etc., etc.? So I co-chaired this group here. So a subgroup from the original ethics group was this one, the COVID-19 End-of-Life Care Horizon Scanning Group and Crisis Management Group. Meeting one was March the 25th. I chair that with my colleague, Catherine Millington Saunders. And the aim is to explore issues around managing large numbers of patients dying from the effects of COVID-19 in the community and the potential need for ethical guidance, and if required, what should advice be? How can we direct people? Catherine Millington Saunders is the end-of-life lead for the Royal College of General Practitioners. And let me tell you, I have been chairing this meeting and doing the minutes and the agenda, and it's a weekly meeting. So we started March the 25th, meeting 1, and on September the 9th, we had meeting 26. So it's all a little bit exhausting, really, particularly when you're as old as I am. The membership, and I'll just keep this up there. This is this membership of this grouping. This is the COVID-19 Horizon Scanning meeting. It includes representatives from all the senior representatives from all the key colleges, the RCP, the RCGP, the head of Hospice UK, the head of the Association of Palliative Medicine, head of Royal College of Nursing End-of-Life lead. We have a large number of people representing charities, such as looking at charities that look at bereavement and end-of-life issues. And this is just a list to give you an idea of the senior decision-making group that we had. And it has to be said, you are the first people to see this presentation. This hasn't been shared widely, the content. So bear in mind that this is, as I said, a first time this has actually been publicly shown. So this is the membership. As I said, a large number of very senior opinions in end-of-life care, bereavement, public health, head of end-of-life of public health UK as well. And our early priorities were, first of all, crisis management. So forward planning to manage potential crisis if hospitals were overwhelmed, no admissions. Interestingly, they weren't overwhelmed. ITU units were. Community support that was hampered by lack of staff, equipment and drugs. Forward planning needed to manage the recovery phase that we were hoping for, which is incredibly unpredictable, uncertain. And resuming normality in care will be tapered with an uncertain impact on individuals and healthcare symptoms. So normality would take a long time to get back. We need to manage that and highlight it. The important thing about COVID is the impact it's got on non-COVID people. And the impact is massive, both mental health and on physical health. There's bereavement related issues, and with limited professional support, there'll be reliance on families, carers and community. So in other words, a lot of us are not delivering the same care that were useful. Outpatient services were shut, investigative services will be shut, and therefore there's a lot of reliance on families and carers in a way that there weren't before, pre-COVID. I hope I'm making sense. Early priorities, anxieties from patients about going to hospital. And one of the big issues has been no visiting or very restricted visiting. That's been a big issue for people and a cause of enormous upset and concern. Many hospitals still have no visitors. And obviously the worry about people going to A&E is, I'll catch COVID. And this was the crisis, the early priorities, management of deteriorating patients with respiratory distress. How do you do that in the community if you can't breathe very well? Accessing medication, I've mentioned it before, and access to hospice may be limited because of workload and actually lack of staff as well. The other thing that really was put on the agenda, as everyone is aware, is the care home agenda. This all highlighted the importance of social care, and it's probably worth saying that everyone needs to be aware that there are 3.5 times more care home beds than there are NHS beds. It is a huge sector. And so some of the outputs, and I'm now going to, so those are some of the early priorities, and we met every week to discuss these. But probably the important thing to share with you is some of the outputs, because I think this is going to change practice of medicine in the future. And one of the big outputs and discussion points is about ACP, Advanced Care Planning. And everyone knows advanced care planning, if you're with a patient, you facilitate it by honest information, discussing about future management, etc. I think we're all familiar with that. Treatment escalation plans are very important. Obviously, we have to assess capacity. We need to know what a person's preferences and wishes are, and that governs the options in the future. And one of the things we don't do very well is have a what matters to me, what matters to you conversation. And I'll explain a little more about that in a second. One of the problems with advanced care planning is that in the acute world, and I don't know if it's the same in primary care, but it probably is to a large extent, there is a huge pressure on having a DNACPR conversation. Do you want to be resuscitated or not? And where do you want to die, home, hospice or hospital? And in fact, the commissioning agenda pushes this conversation. The joke is when you have a seriously ill person with multimorbidities, you can't resuscitate them. So why do you have a conversation about DNA CPR in someone where it's a futile intervention? That's something for discussion. And home, hospice, hospital, we change our minds as our illness progresses. We all change our minds. And in a hospital practice, junior doctors can spend a long time on DNA CPR, where do you want to die, as opposed to individualized care planning and what matters to that individual person. So ACP is a huge issue. And what's happened, this has taken several months of meetings, is an advanced planning charter has been developed. Advanced Planning Charter 2020. And I'll briefly go through this list because these are the key points. This is about having conversations about what matters most. It opens the door to how health and social care services can find ways and enhance meaningful aspects of people's lives. Conversations evolve over time, therefore advanced care planning, or advanced planning as we now call it, actually isn't a point in time, it's a process. It's not about doctors, healthcare professionals, what matters most conversations can actually begin in the community. And actually, there was a lot of talk in these meetings about, why don't we talk about dying? Because we're all aware that people die when we're in school, you know, when we're in college, we talk about life matters, but dying is part of life, if you understand where I'm coming from. It happens to us all. You know, why isn't this a more normal part of our lives? We spoke about death and literacy, community participation, and the overarching aim of all of this is to help people live as well and fully as possible, but actually they've got to see death as a part of life. So there's a charter that's been written. I haven't got the charter here. This is just a little sort of section of it. And the charter is basically a document that's being presented to national bodies and to government to say, actually, the DNA CPR, where you want to die conversation has got to be shifted into a much more broad and meaningful conversation. So where are we with the charter? Well, the charter is complete. There are some background documents, and there's a summary document available. All the end-of-life stakeholders in the NHS and third sector have seen this and are now signing up to the charter. What we are doing, and don't forget, this is a process. We are going to a lot of senior groupings in the NHS and the voluntary sector and saying, we want to shift emphasis. The charter is to shift emphasis. It's got to progress conversations about what matters to you. It's a community process. So this is a process rather than just a charter, a tick box, yeah? And what we are doing now is we are in the middle of producing a brief film called Talk AP, Talk Advanced Planning. And that film is going to be used for public and professional consumption to try and help people understand where this message is going. So a complex move in a direction. We're moving away from a sort of risk management excuse me, harm management process into a much more meaningful way of having conversations about end of life. So I think you are going to see some changes. Okay, what's happened to symptom management? So that's advanced planning. So management of distress, up-to-date clear information regarding medication. What we have done is through the Royal College of Nursing and this group, we've enabled people to reuse medication. The law has changed. And so this group, so what used to happen is you used to get a whole bucket full of, let's say, diamorphine, morphine and midazolam in the house. The person used to die and there was a load of it left and it used to be thrown away. But now we can reuse that to prevent shortages. And again, GPs and home care teams can now take out pre-packs. I used to do that in 1985, but it was stopped with, proper meds that you need to manage end-of-life distress. So symptom management, we've done a lot of work on. Coordinated care, looking at how we try and bridge the silos. Rapid response units, collaborations have been looked at. I'm going to flick through this one. And then I think the most important thing is about public health engagement. I think one of the big issues is some of the big issues are we need to have good information about rising tide. So in other words, if we've got good quality information about how many patients are not attending accident and emergency, how many are not having acute investigations, how many are not being seen in outpatients, then if we know about numbers, we might be able to plan to ensure that we can mitigate the risk. Hospices being overwhelmed, is that going to happen? Again, the answer is we don't know yet. We need proper data to enable us to manage that situation. And just a mention of community support, we need data on lack of staff. Actually, it's a big issue, lack of staff being put off on 2 weeks. Absences because of holidays that they've gone on, and children now who are coming with a sniffle and they say, oh my gosh, it's COVID. One of my consultants hasn't been in the building today because their daughter has a sniffle, has got to be COVID tested. Numbers, medication shortages, oxygen shortages. Oxygen shortages was a big issue with wave one. Care home data is very important, and palliative care team availability. We need this, and we've really got to think about this as end of life care as a public care. Resilience we've spoken about. And we have to be mindful of the fact that I think when COVID first started, everyone was keen and enthusiastic to do what they possibly can to make everything okay. But now we're dealing with a large, including me, a large number of exhausted, worn out, fatigued people, and there's a second wave is coming on the news every day. I think we're absolutely, you know, I just think we're all thinking, oh my gosh, how on earth are we going to manage this? And certainly all my colleagues are in that zone. So resilience is important. Of course, patients and families, you know, limited professional support, reliance on families, care homes, the staff feel undervalued. And I'm just picking out a few points here. Volunteers, there were 1 million volunteers who volunteered, of which the NHS only used 200,000. And therefore the volunteer grouping is a little bit peed off, I think, because they weren't pulled in to help. System change, clinicians, I think it's very important that we have to recognize the stress that we have in our colleagues. I think particularly in primary care, actually. And I think, you know, unrecognized stress, virtual consultations, it has been, and at one level, I can see the value of them. On another level, it's been a nightmare. And I have seen several patients face to face in whom were fine on a virtual consultation. And when they've turned up in my consulting room, there were clear physical problems. Multiple deaths that you've got to, you know, has an impact on people, and we're all exhausted. We're all exhausted. The last big document that went forward is Health Select Committee submission on bereavement. And I'm going to do this very, very quickly. So just ignore the stuff on the right of this slide because I'm mindful of time. So we had we got together, in particular the Royal College, Marie Curie, the charity, Compassionate Communities UK, APM, Associated Palliative Medicine, Cruise, Age UK, Sudden and Break. We got together to look at bereavement. And the first thing is, as I keep mentioning the word public health, when we think about bereavement, there are 3 tiers. And this is went to the Health Select Committee, the Government Health Select Committee. And the volunteer tier, tier 1, a supportive response from existing networks in a community. This is a community response to bereaved people. This is about bereavement. And actually, the volunteers that are there can be mobilized to provide support for their community. And I think in the Jewish community, it's particularly important as well, in terms of we have communities around synagogues, etc. You know, we need to be mindful of that. So the vast majority of people need this sort of support. Some people need tier 2 support, easy access to consultative process. So these are GP, community nurses, social and link workers, bereavement services, etc. And then only a few people need specialist psychological support. So when we're talking about bereavement, and this is the Health Select Committee, is about using volunteers, helping with bereavement. This triangle is a very useful document. The bereavement crisis is there, complex, increasing numbers, social distancing and no visiting, as I said, made huge difference to the way in which people manage the death of their loved ones. Sudden deaths happened in all settings. Interestingly, one thing we haven't got yet is what's happened to the suicide rate. And we know from the ambulance services, they were called out, went to the houses, and they were able to certify deaths, and they saw a lot of sudden deaths. And we think some of them were suicide. Unsupported bereaved people leads to isolation, poverty, PTSD and suicide, etc. So the bereavement thing is important, and there's a long-term burden on all services in bereaved people who aren't managed appropriately. So we need an early community-led and supportive response. Psychosocial services, the Health Select Committee application is looking at online information for bereaved people and communities, and we're looking at proactive support for those with heightened vulnerability. So this includes children, so it's safeguarding, community providers, compassionate conversations, signposting for longer term care. We need to communicate care homes. We've mentioned care homes, but this is in the Health Select Committee report. They've witnessed more deaths. They're an undervalued workforce. and their ability to carry out end-of-life care and advanced care planning was really tested in the previous crisis. The PPE challenges just added to the stress, and there was a loss of staff through sickness and stress. That was very significant, actually. And this diagram here is a sort of summary, putting it all together document. And this basically says that bereavement, end-of-life care is a public health issue. Public health palliative care, public health end-of-life study units, FELS units need to be developed and funded. Compassionate cities, Manchester is going to be, Andy Burnham has said he's interested in this, compassionate cities. Clearly research is important. Primary care participation, but working with secondary care and NHS personalised care. And I apologise if I'm flicking through these slides, but I'm trying to summarise 26 weekly meetings in 26 minutes. So I do apologise. I just hope the words are helpful for conversations. What about now? So the group has met. It had its early priorities. It developed 3 major pieces of work, particularly the Health Select Committee application and the Advanced Planning Charter. What next? So this is the agenda from the last 2 or 3 meetings. And what we're trying to do is highlight the unintended consequences that have happened because of COVID, the issues that need escalation, and we're trying to get ownership of some of these issues to make sure that we can mitigate problems before they arise. And this is a powerful group with very senior people, so hopefully we'll be able to do that. So let's just go through the list. Winter planning, second wave. Everyone's aware of the second wave. The non-COVID activity surge, we've sort of mentioned, but we know that is extremely significant. Everyone is saying there are problems because people haven't been seen or attended or haven't come. Children, big issues on bereaved children. There's some work being published on that. Care homes, fatigue staff, we've spoken, the staff are abused, and litigation. I think there's a big issue about litigation. I think a lot of people who haven't had appropriate cancer care, for example, when they get the recurrence, are going to think about litigation. And I think the other big issue is reduction in voluntary sector funding. And just to reinforce this, I put this in about 10 minutes before the presentation. There was an article in the BMJ. Charity cuts could put the NHS under even more pressure. I work for Marie Curie. Marie Curie has a turnover of 150 million, and the estimated shortfall is going to be about 30 million. It is very, very significant in all charities. For all of us who are engaged with charities, please be mindful they're struggling, they're worried, they're anxious, and the NHS is going to feel the impact when there are cuts, and therefore this needs to be mitigated. The agenda now, future planning, information overload, go back to that. Drug reuse, testing, no need to tell you about testing, it was in the news this evening. Virtual consultations, we need to look at the upsides and the downsides. There's been a series of publications on the downsides of virtual consultations. I think we need to share that. There we are, that's me. All the computers, the bloody phones going off, oh my gosh, yep. So, you know, managing information overload. And if people like me who are working at a senior level in a charity and is struggling to manage the information that's being catapulted to us every single day, just imagine how it impacts on the district nurse in the community, for example. We really need a way of managing the massive amount of information that's coming through. I've given you a load of information tonight, so, you know, it's just sort of reinforcing. Agenda now, future planning, research to assess the impact, and we need to oversight those 3 big projects I mentioned: advanced planning, bereavement, Health Select Committee application, and how to use volunteers more effectively. We are talking to someone called, I think it's Paul Reddish from NHS. You know, no, it's not Paul Reddish, it's someone else. I think it is Paul Reddish, who is looking after NHS volunteers. So he's going to be part of this group in the future. And we then got to look at the opportunities. Therefore, we've got to get something positive out of all of this, the COVID stuff. And a few things to mention. So primary care and secondary care have been in 2 different camps. We need to look at seamless working between primary care and secondary care. It would work a lot better and might help break down the silos. Integrated working with social care, that particularly is highlighted by the nursing home agenda and how that has impacted on the whole healthcare. So we've got to work together. Compassionate communities, I've mentioned that in the Health Select Committee stuff. FELS units, these are Public Health England units. They need to be created, end of life units, sorry. Managing negative media, we need to have a little think about, because we're going to get, I think we're in the days of negative media, but the most important thing, I guess, is we do have to celebrate the success. I chair this primary care group, and actually most of our primary care physicians have really sort of worked their butts off to try and make everything work. How much energy people have to do that, who knows? So lots of new things to think about. Many apologies for gabbling through all of that, but I just wanted to highlight some issues. I do hope this was helpful. I do hope this was helpful. And I think we've got to start, I started saying we knew we had to think in a certain way right at the very beginning. We definitely got to think of a working in a new way. And just as a sort of downside, the other thing about COVID has become the biggest excuse that a lot of senior teams have used to make changes that they were going to make anyway. We need to be mindful of the positives and the negatives. So thank you for listening to me. You're on mute, David. David, can't hear you. You're on mute. David! If anyone can get through to David.
That better?
That's better, David.
That's better. Okay.
Sorry.
Right. You can hear me now.
Yeah.
All right. So thank you. Thank you. And thank you very much for a tour de force. There are a couple of immediate questions that strike me while other people are coming in. One was, you mentioned the ambulance driver death certification. Is that a good idea? Is that a bad idea? How are you recommending that death certification should be done?
Do you know what? I'm not sure the answer to that, because I think one of the things we've got to do is do this on a week-by-week basis. So the reason why ambulance drivers were doing more of the death certification is because they're basically GPs were overwhelmed, they couldn't get out to the houses, etc., etc. So perhaps not in the longer term, but I think we need to manage. I think one of the mistakes and errors that has been made in this whole COVID crisis is saying in 3 months' time, in 6 months' time, there's so much uncertainty there. I don't think we can think like that, to be honest with you. So I think, yeah, it was the best we could do at the time.
The other thing is that you, at one point, you mentioned the hospice, and you said you separated out care homes, and the care home sector is much bigger. Is there any room for, if you like, hospice staff to be attached to, or not attached to, or seconded, or somehow help with the care home crisis?
Well, end-of-life services could do that, and it's quite interesting, Otto, because there's a lot of discussion now between Marie Curie, for example, and the nursing home world. And we also presented a project not that long ago. So the thing about care homes is, and all those who work with care homes, is the people who run the care homes are often quite, are often seen as second rate, and they're not. Yeah, and they are definitely not. So one of the things that happens, if you go into a care home, the person who runs it knows when someone is dying. And therefore, I've always thought you need some sort of end-of-life facilitator who knocks on the door of the care home and says, any of your residents likely to die in the next week or two? And if that's the case, then you can put in additional resource to try and manage that. The Canadians use something, and I've forgotten the title of it, whereby they do this virtually. So what happens is, if you have a dying patient at home, they have someone who sits by the bedside, and they use virtual consult. They virtually ring up a senior nurse and say, I'm looking after Mr. Jones, I'm by the bedside, he's got lots of pain. And the nurse says, give him some morphine, give 10 milligrams of morphine. So this virtual working is being explored with the care home sector to try and get end-of-life expertise by the bedside, but it has to be done in an economic way. So in other words, I think what I'm saying is, David, is care homes are very important. End-of-life care for some patients for many patients can be delivered at the care home. Many palliative care teams working in the community are linked with the care homes. And if you give good end-of-life care in a care home, you prevent hospital admissions. There's no doubt the data is there. So I hope I've sort of made a little bit of sense, David.
Do you see what couple of questions have come in? One about bureaucracy in general. Do you see bureaucracy rolling back, becoming less, or do you see it coming back in again in full force?
When you say bureaucracy, what exactly do you mean?
Well, that's asked by a questioner.
I have strong personal views. I used to be medical director of the Royal Free, did that for 7 years. I've seen executive teams in the NHS in the voluntary sector. So I have strong views, which I'm not sure who's on the call, so I'm not sure how much of these I can share, you see, David. I have strong personal views.
We're going to have any hospital administrators?
Well, I did have a big row with Jeremy Hunt over this one. I think that what has got to happen is that the senior teams, the trouble with senior executive teams, not all of them, but some of them, they treat senior medics or junior medics as train drivers. Yeah, I'm saying something I'm probably going to regret saying this. What train drivers are, they're really important to drive the train, but there's another one round the corner. So at one level, that not all executive teams, not all bureaucratic teams do that, but number one, that they do have this thought. The other thing is, I think that compassionate clinicians, whether it's nursing, medical, social workers, whatever, can only be compassionate and happy in a happy and compassionate organization. Culture is set from the top. So I do think there has to be a belief that all healthcare workers go to work to do a good job. I think that's the belief. If you believe that, then I think authoritative voices, bureaucratic voices, would think differently.
Right.
And as you know, we're living in a system which is very blame focused, and it shouldn't be.
And about the other question raised is about the question of these reuse of packs and that system. The reuse of packs is the complaint I've heard outside this as well, is that this is being taken over by the pharmacists, and there's also concerns about, about the drug company agenda, that they of course like packs to be disposed of, not to be used. So both of those elements are important.
No, absolutely. And there's always a downside, isn't there? There's always a downside. But at the time of reusing medication, there was a real fear that people were going to run out of. There was going to be a lack of, a running out of. It was really out there, and that is one of the reasons why reuse was put into place. The reality was it probably wasn't necessary.
Right. Okay. There are a couple of questions about the coroner service. Are most adult deaths from COVID discussed with the coroner? And what work is done to improve the ability to contact coroners when you've confronted with unexpected deaths?
I'm not sure. I'm not sure I have the knowledge. I mean, I only know the death bit from my own hospice. So I'm not sure I can accurately, and maybe there are other people on the call who can answer that one. Not sure I can, though.
Well, the one about the reporting to the coroner, I think you can answer. Are all deaths reported, COVID-19 deaths reported to the coroner?
Are all COVID-19 deaths reported to the coroner? I don't think so, but I'm not sure.
Yeah, the answer is certainly is no.
Yeah.
But I suppose I can answer that one. And
go for it.
I'm cynical about this because if you're not reporting to the coroner, then when you come to make a claim for somebody being responsible for the death,
then
it wasn't reported to the coroner, so there's no unsatisfactory information. So as a result, the government can get away with it.
And I think you'll find, as I mentioned, I think litigation is going to be a huge issue, David. I'm waiting to. There's been a few little sort of things happening, but I think it's going to be a big issue. I think you're going to get people ringing up, like with have you had an accident recently? I think you're going to say, have you had a member of the family who's died of COVID recently? I think it's going to be a big issue.
And then the other thing about that was, were these ambulance drivers ever reporting death to the coroner, which the unexpected deaths, which you say may have been suicides? Were the ambulance drivers, as far as I'm aware, have not reported?
Not that I'm aware of, but as I said, I don't have the. Yeah, I think that's right, but I don't actually have the factual details on that one.
Advanced care planning.
Yeah.
The ACP. The one issue about advanced care planning is that there's this question of, lodging your intentions and doing a legal document. And one of the issues that was raised in the organ donation field was that it's quite expensive to actually get one of these formal legal documents organized.
Yeah, I'm not sure. I mean, you can. There's the My Living Well website, for example, that is that's out. So I'm not sure that's true. Actually, I think you can do a living will, which is the old-fashioned term, advanced planning document. That can be done online if you want to. But in terms of advanced planning, in terms of the medical world, if you see what I'm trying to say, the advanced planning is very focused on where do you want to die, and do you want to be resuscitated, which and people are really assaulted by those conversations. You need a very different conversation. And the film that we're making on advanced planning, some of the questions are going to be like this. What are your wishes? What matters to you most in your life? That's an important question. What drives you? What keeps you going? Do you want to answer me, David? How long would you like the last part? How would you like the last part of your life to look like? What would you wish from those who are around you? Have you discussed your wishes? Have you discussed them with your people important to you? Those are the sorts of questions. They're the scripts that I think people need to have a meaningful conversation about advanced care planning. Of course, at the end of the day, it may be important that we document somewhere about resuscitation or not. We've been doing it for the last 30 years, 40 years, 50 years, but I do think we need a proper conversation. I think many of us, and I've seen some of the questions flick up and chat flick up, I think many of us are finding advanced care planning, a very not a constructive process.
The issue that's being highlighted in the press is the question of families' access to the end of life in hospitals, particularly. I mean, is that something that is being addressed in any kind of, for the second wave? Is it something that's being addressed in any more sympathetic, if you like, fashion?
The answer is probably not. Because I mean, and I've no need to say to an audience like this as to why they've restricted visitors. We all know why, but the distress that this has caused has been enormous, and the rules are very unclear. There are some hospitals, many hospitals, who do not allow visitors. The hospices have had to change the way in which they allow visitors. For example, we now have 2 visitors allowed between the hours of, oh gosh, I've forgotten the hours now, 2 and 7. Yeah, but we can have families there if someone is dying outside those hours. 2 families, some visitors. But I mean, the restriction in visiting, it's been, you've got to reduce footfall in a hospice, for example. You've got to reduce footfall in a hospital when there's an epidemic, a pandemic out there. But it has caused enormous upset. There's no doubt about that. Right. And I think, and we see more complaints in the hospice, many related to visiting, and we are moderately lax about our visiting policies compared to others, just for example.
But what about in the hospice? Presumably the patients are not COVID-19 patients, they're other patients.
Yeah.
affected by the COVID-19, about the COVID-19 pandemic going on. Those patients are also therefore not having anybody from their family come and see them, which is the one of the complaints that come through in the surveys that I've seen, says that that's very unfair.
Sure. And what, some of this is about restricting footfall.
Yeah.
That's what it's all about, because if you have hundreds of people walking in and out, and often this is what we see, in normal times, large numbers of people, particularly certain ethnic groups, you have these large, all hanging around the room. Yeah, I understand that is how, that they function and they work, but you have to reduce footfall, and yeah, and you've got to keep your social distancing as well.
And the one question that then relates to the forthcoming second wave is the proportion of people that you feel are going to end up with in care homes this time round. Is this going to be a major problem? And is there any way of providing help centrally from hospitals and hospices to the care homes?
Again, I'm not sure. I mean, we mentioned before there are new initiatives, but they're going to take a time to get into place.
Yeah.
I think people are going to be more aware of the importance and the relevance of care homes. Of course, what happened is they didn't test people when they sent them to a care home from the hospital before. They're going to do the testing now. They're going to do regular testing of the care home staff, we hope, but who knows? Who knows? I don't know is the answer.
Do you think?
And I don't think that's out of ignorance. That's out,
Yeah. Do you think you've mentioned public health, the connection with public health, is what will happen to this kind of issue if Public Health England is disbanded?
Yeah, no, you're absolutely right. And in fact, that was a conversation we had last week. And again, I think it's a statement, David, that you've made that probably doesn't have an answer at this minute in time. What will they put in place? I mean, this, yeah, it was quite, at one level interesting when they said this, but actually quite unbelievable. And as I said to you earlier on, COVID has become some large organizations' best excuse to make changes that they probably planned for a long time.
Right. Well,
but I'm a cynic. I can't help it.
I think that you've given us an overview of a rapidly changing field and a rapidly evolving field, but at the same time, you've given us a core of stability in experience. And I'm reminded of the fact that we had previous discussions on the series in which people have highlighted the importance of professional leadership. And we're grateful to you for having shown that professional leadership in this complicated field. Thank you very much.
Pleasure. Thank you all for joining me at this time of night. It's time for a gin and tonic, I think.
And all the best for the weekend, Rosh Hashanah, and follow the guidelines that have been by the government today.
Yeah. Thank you, David.
Thank you.
A night, everyone.
Night.